This week on our podcast, we have Erin Athey, an NP in DC, who has a very, very unique model. She's partnered up with the housing department to take care of patients in public housing. You don't want to miss this because you're going to learn so much from Erin. So, NP Erin, so excited to have you here after all this time. Thanks for being here.
Absolutely. Happy to be here.
Amazing. So first, tell us, what state are you in?
So I am in Washington, D.C. For the last 20 years, practicing in Washington, D.C., actually.
Wow. Okay. And how long have you had your own practice?
So I formed C3 Cares at the end of 2021, but really kind of started in 2022. So about 2 years.
About 2 years. Okay. So what is the...
New. Still very new.
It's still new? I think for a lot of us, it's new, right? It's relatively... with the exception of some states, for a lot of us, it's new. What was the crazy reason? What was the crazy reason you decided to own your own spot?
Yeah. So to be very honest, it was like never part of my plan to do that. I was in academia, and I was teaching, and I was doing a lot of community research. And so during the pandemic, I was running mobile clinics through the different housing properties, doing mobile vaccines, doing screenings. And that's kind of when I got this idea to create this sort of new model of healthcare delivery. And so I had this idea. Then I saw that there was saw in my email that there was this application for a quick fire challenge award through Johnson & Johnson. And I thought, okay, so the whole thing was for nurses who want to improve access to care. And so I thought, let me try this. I feel like this could be something that we could, try out. And then I won. So there it was. And that's sort of what got me out of the gate.
Whoa. Okay. So
yeah.
Or did you ever think of opening up your own place before this, or like this, like a drive that you had?
Yeah, it was kind of part of it. But like I said, so I've been a clinician for a long time, 20 years. Then I was in academia for 12 years. And so I think I had different ideas. And I think it was always sort of inside of me. But then when this opportunity came up, I was like, okay, why not? Let's go for it and try. And then I just sort of did it and kind of gave up everything to do it. So
like, wow, I really want to open up my own place. It was like, oh yeah, let's just find out.
It was kind of like that.
Was there a backup plan? Like, if this doesn't work out, what am I going to do?
I kind of slowly eased into it. So I was a full-time professor, and then I started to go part-time. And then I eventually just sort of quit out all of that, and now still adjunct, but definitely have made this my full-time gig.
And
yeah.
How many patients do you see a day at this point?
So right now, it's probably important to say that this is a little bit unique and different than just like a regular practice. So right now, what we've done is taken 2-bedroom apartments in public housing and converted them into these little mini clinics. And so I was very fortunate to, get the support of the DC Housing Authority, who runs the public housing in DC. And so they have given us 4 locations, but they're mini. They're like small little mini clinics. So we have 4 of them right now. They're not operating like full-time Monday through Friday, but we're really just starting to open all of them. So we have 2 of them that right now that are operating. And so we see, it depends on the day. Our population is very unpredictable, I'll say. These are the folks that usually use the emergency room for the primary care. So we're really trying to change a behavior, not just provide the service. So we see between, 10 and 20 patients a day, depending on the day.
So what do you mean you're trying to say behavior? Like, in other words, you want them, if it's a walk-in, like, oh, I don't feel well today. Instead of going here, I'll go here.
Yeah, I mean, it's more, I think, for our population, at least the Medicaid folks that we're serving in DC, their normal practice is to go to the emergency room for everything. They don't really have a deep engagement with their primary care providers. Some of that is because sometimes it's a long wait, maybe 3 or 4 months to get an appointment for a primary care appointment. So we're trying to say to them, don't wait till it gets too late. Don't wait until your blood sugar is 800. Come see us for your regular checkup. Come see us and, get a physical. Or if you're starting to feel unwell, come sooner rather than later. So we do accept walk-ins. We do have appointments also, and people can call and schedule, but we leave a lot of space in the schedule for walk-ins because we know people's lives are unpredictable. They may not know what's happening tomorrow, next Tuesday, or 3 months from Sunday. So we really try to be more flexible with the model. And we're really still just trying to kind of work it out because we're still pretty new.
Wow. And so with that, with understanding the special populations, still how many-ish a day walk through your door?
Yeah, like between like probably 10 to 15, sometimes 20 on a busy day.
10 to 15. Okay. That's nice.
Mm-hmm. We have some volume. I think it's just what we would love is they come like, 9, 9:30, 10, like that. What we tend to see in our clinic, like the morning ones are not so popular. We get the blob in the middle of the day and we get a little later in the end of the day. We usually get, yeah.
Interesting that you get in the middle of the day. I think most practices are like first thing in the morning, then kind of dead midday, and then super busy at night. But you have it. Why do you think that is? That you have like this middle of the day blob?
I think it's kind of like the ones that are the morning, they kind of run a little late. And sometimes this is for no fault of their own. I mean, quite frankly, I think, even our folks in DC, they get transportation through the Medicaid payers. So, but sometimes they're late. Sometimes it's not perfect. I mean, I feel very sympathetic because I think, sometimes these other clinics are saying if you're 15 minutes late, you can't be seen. You've got to reschedule. And so for us, we understand that there are a lot of social issues, a lot of social determinants that affect people's health and the way that they access health. So for us, we're flexible, but sometimes that means the morning ones kind of smush into the middle of the day, yes, and then it kind of clumps up. But it's, yeah. And then sometimes people are just checking us out like, oh, what is this? It's like a little mini clinic in public housing. So they might just be like strolling in and might be, oh, can I be seen? You can, but you have to wait. So it's kind of like that sort of thing.
Oh,
but yeah.
Interesting. What interesting model built into the public housing. It's a great concept. But then do you use still like billing the way other practices use?
We do. Yeah. I mean, we're still pretty much fee for service model with all the payers. We have mostly Medicaid, we have Medicare, Medicaid patients. We do take private insurance too. So sometimes people come into our clinics. I don't know that they are always aware that we're in like a public housing building, but that just goes to show you that they're like cute little clinics that people stroll in and find through their private insurance, and they come and see us also. So,
well, that's because it's open to anyone.
It's open to anyone.
I love that.
Yeah.
So what's the biggest challenge in putting this together? What would you find the hardest thing? I feel like every day is a challenge when you have your practice, but.
Yeah, I think this is because this is a unique model. And so my vision for this really was never to just be like a doctor's office. Really, I see this potential to be more like a wellness hub inside of public housing buildings. So in addition to the clinics that are primary care clinics, we're also offering education sessions to residents. So we use the community spaces inside the building. I still take nursing students from several universities, and we come and do education talks on, diabetes and hypertension. And so to me, it's like, we're really trying to create something new and not just go off an existing model for primary care. Because to me, I see it not working in so many different ways. And so trying to address health literacy in the communities, which is such a big issue. People that come in, they're carrying 2 sticks and they say, these are my diabetes medications. What are they? They really need time. And so to me, it can never get done in a clinic, in a 15-minute visit and a 20-minute visit. So how can we create a space where we can do clinical services, but then we can also do some of this education, address health literacy, maybe provide, some vaccines and stuff outside of the little mini clinic. So we're really trying to create this wellness hub model versus just the clinic. So
if I'm hearing you correctly, I'm hearing that the challenge, tell me if I'm, speaking out of turn. This challenge is that you have a model that's service billing designed for the 15-minute visit.
Yeah.
Patient population needs so much more, which it cannot be accounted for in this fee-for-service, right? Because a 99214 doesn't really include all the time needed to walk someone through how to use their, diabetes pen. And you're trying to create a different model, but
right.
The current model that exists, the puzzle pieces don't fit.
Yeah, I think that's totally it. I mean, I think we're trying to exactly work within what currently exists in the model, in the medical model, but we're trying to create a nursing model. So how do we do that? We've got to play by the rules, and we've got to, bill the services, as you said, like we do in the clinic, but we really know that more is needed. And so how to do that. And so I think we're trying to creatively find ways to do that, because we know that it's not just going to take place in that little clinic and, on a one-on-one encounter. It's going to have to be more than that.
And it's not really just a nursing model. I mean, nurse model is great, but it's really social determinants of health, right? Because we know that access to care is really like a small percentage of what actually people need to be healthy. They actually need all the other pieces. And I think, there is a push in 2025 to be able to get some reimbursement for that SDOH work, but currently, right now, there isn't. And so, very interesting. That is how do you see, or do you see a solution for that? Because I imagine that, especially the population that you are working with, this need is like a gaping hole. It's never going to get filled. So how do you make that economic adjustment of the time that you need for this population versus what you actually get reimbursed?
So we currently are operating only because we also have other contracts. So we now are funded by the DC Housing Authority, which is really amazing. We started off by having some grant funds through COVID. We had a couple other grants through DC Department of Health, but it really is because the director of the DC Housing Authority is highly supportive of this, loves the model, and is now putting some money behind it. So yeah, based on just a fee for service, just to pay for the staffing and everything we need, we wouldn't be able to do it just based on billing at the moment. Yeah,
no, I'm glad you're saying that, because some people listening think everyone listening wants to do what you're doing. Everyone wants to spend time with the patient. Everyone wants to spend time educating. I mean, I don't know a single NP that comes from being a nurse up the ranks NP who doesn't wish they could spend more time with their patients.
Yeah.
And it's not economically designed to do that. And the fact that you are able, that I think it's edifying to those of us out here who are like, wow, I wish I could spend more time. Hear that the only reason you're able to do it is because you have like this outside source. I think it would make a lot of people who are listening be like, oh, okay. Okay, that's how it works.
Why is it? Yeah, exactly. Yeah, no. I think that's actually, thank you, because I think that's a really good point. I think that currently the way things operate, and I know you and I have actually spoken about the value-based care and sort of that model sort of in the future. But when you're getting started out, no one's going to give you these contracts for value-based care, right? You got to hit a certain volume. You got to be established. And so even to negotiate some of these talks, which I tried to in the beginning, to be really honest, I talked to some of the Medicaid payers. And I said, well, what about, can you just give us some patients and give us a monthly, amount to take care of them? But everyone's just kind of waiting to see, like, well, what are you going to, like, are you really going to pull it off? Right? Like, can you really do this? And so because that we're not there yet, we are supplementing with these other funds, which, thank goodness, because otherwise it wouldn't work. Yeah.
Wow. So for anyone listening who doesn't know what we're referring to, is the value-based payment, right, is when insurance companies are saying, oh, wow, Erin, you're doing such a great job with all these patients. Because you kept all the patients A1C below, 7, we're also going to pay you for keeping their costs down. The problem, as you alluded to, is that you can only engage in these contracts once you have a certain amount of patients. For sometimes 500, sometimes 1,000. Right. And so you're doing all this work, but you're not getting that extra income. So anyone out there who's listening, if you're not in value-based payment, it probably just means your patient population isn't at the larger size yet. But don't worry, it's coming. It's coming because there's enough patients. Oh my goodness.
Yeah.
So you have like this challenge. How does it feel overall like to be a business owner? And just like shakiness of it.
Yeah, I think you definitely get the imposter syndrome going in the beginning. I always laugh because it's so similar to how I felt when I started as like a new professor. I showed up and it was like, okay, here I am. It's like, what questions do you have? And you say everything, right? Like everything. I don't know what I'm doing. Help me, And so it's the same feeling of being an entrepreneur and like, where do I start? Like, how do I get started? I do belong to some professional organizations for nurse practitioner entrepreneurs. I think that's extremely helpful. I felt like that helped me a tremendous amount in the beginning. Like, okay, what do I do next? Like, how do I get going? I have a little bit of funding from J&J, which is a nice little gift, but still no one's giving me the playbook for this.
Yeah.
So what do I need to do? And I think some of it is kind of stumbling and bumbling. But I definitely had that in the beginning. And then I think as you go, you start to get some skills and you start to understand it. It's very different than the skills you need to be a clinician, obviously. And then for me to be in academia, very different than that too. So the learning curve is steep. But I think so many nurses are so good because it's a lot of grit, right? And trial and error and finding workarounds and just really getting in there. And I think a lot of us are kind of used to that being nurses. Like we're just figuring it out. If we're in the hospital, if we're in the clinic, it's like, we got to make this work. How are we going to make it work? And that's a lot of what being an entrepreneur has been for me, is just figuring it out, how to get that cable wire under the public housing building so we can set up our internet so that we can get onto our EHR. So like that was, that was a little different.
You have said so many important things. You said so many things. I want to surface them. First of all, thank you for saying you have an imposter syndrome. I mentor a lot of people through Duet, and people think they're the only ones who have this imposter syndrome, and we all have it. And and I'm sure you have it now in different areas. So like you're better here, but then so it never goes away. The feeling never. Totally. The imposter syndrome. Right. I always say, depends what room you're in, right? If I'm in a room full of fifth graders, I'm feeling pretty awesome, But if I'm in a room with people who are like 10 years ahead of me, I'm going to feel like a positive. So I also tell people who I mentor, the difference between you and I is just time. It's just time. That's right. I'm not better, smarter, faster, stronger. I've just been doing it longer. So if you just get enough time under you, it's going to be okay. So I love that you share that, because I think it's very important for everyone to know that none of us know what we're doing. And we figured out, and this is not teaching. This is a business.
Exactly. That's true. It's across the board.
Clinically, where we know what we're doing, but like as business owners, no business knows what they're doing. I'm probably going to say this 100 times on this podcast. We don't know what we're doing. And I'm always going to asterisk, I don't mean that clinically. I mean that business-wise. I don't want anyone coming at us. Absolutely. So I'm glad that you said that. The other thing I'm glad you said is like creating a network. And I think, I think you were in the early stages of Duet, but Duet now has become this robust network for NPs. And it's this place. When I started 10 years ago, I had no one to ask anything, and reaching out to people, creating a network, finding people, and being vulnerable and saying, how do you do this? Like, don't be embarrassed, because we're all figuring it out. And there is no playbook. Yeah. People are like, well, I wish can you just show me which website? There is none. Good luck reading CMS.gov. It's okay to be lost. It's okay to be lost. I'm so glad that you mentioned all that. He's shaking us. What do you love about this?
I mean, to me, it's just like there are always opportunities. And I love that, because I think now that we're up and running, I love that it's like creative work, that I haven't always had. Like, okay, well, how can we make this work? And if we, are setting up this clinic over here, like, what do we need to consider? I also love community health, like really big L love community health. So to me, it's fun trying to think about what partners do we need in this? So our model is in public housing. It's kind of like I say, it's like an FQHC model flipped inside out. So we have social service providers like in our buildings doing different things. So to me, it's always like, okay, we have this patient population. We're going to provide clinical care. We're going to, provide primary care, but who else can we bring into the table? Like, who else can we partner with? Does it make sense to kind of have these people here to do this thing and help us with this service? So that part is really fun. And then I think probably the biggest thing is just seeing the patients that are happy, and they're like, okay, you guys are caring and you're nice people and you're here in our building. And they're so happy, and there's a lot of joy. And so I feel like even though we're not huge scale at this point, we're still just kind of forming these clinics. But I just think already we're making small differences in people's lives, and it's just amazing. Yeah.
You're making huge differences in people's lives. And this is one of those professions, you impact so many. You impact so many, and we all do, but you're particularly impacting the people who know everyone else has forgotten about. Really big deal. And you were just like, let me just try it. I have no idea if it's going to work out. Let me just try it. And I love it. That is amazing. Wow. And how did you learn? Like, I know a lot of people really struggle with like learning billing. How did you learn how to do that?
So I had a service provider that helped with the billing. And so that's kind of because I think one of the things I knew is like, there are things that I don't know that I actually don't care to know. I actually don't want to be doing those things. So I knew that very early on, like, it's very important to know these things. Like, I will say that, just like caveat, like important to understand the billing, coding. A lot of us, when we got our training as NPs, we're not super well versed in coding. We may have been out in practice and doing it, and maybe someone was fixing it on the back end.
Yeah.
But those things are very important. But I did, I hired a group to do this part for me because I knew that was not going to be part of what I wanted to do. I really wanted to maximize the patient care and also kind of think about the model and how to get it going. So yeah, I think that is something to consider, but also something to consider about like, selecting someone to do that part, because there are different companies that do that. So really thinking through that.
The parts that you don't like.
Yeah.
Delegations?
Well, and you can't do it all. I mean, maybe you can do it all if you have like a very small patient volume, but if you're thinking about having a larger practice where you need a certain volume of patients to keep things going, like you are going to have to hire some folks to help you, an office manager, somebody that can help you with that stuff. So
can't do it all. And you want to work at the top of your license. You want, right? No one else can see the patients. So if you're doing something that someone else can do, it's great that you early on discovered the power of delegation, because you can't do everything. You'll burn out. And you're not going to do it as well as someone who this is what they do all the time.
Exactly.
That's really, really good that you have that. If all goes well, where do you see yourself in 5 years?
Oh, goodness. 5 years. The 5-year question. I hope that I can scale this in DC. I really, my goal is to continue to work with the housing authority, and I've good, signal that they are very interested in scaling this across the district. I think that, I think the model has potential to grow to other cities. But I think in the next 5 years, if we could have a good, stable network of these clinics, DC alone has like over 50 public housing properties. So, there's senior buildings, there's disabled buildings, there's family properties. And so to me, if we can spend the next year or two really solidifying, like, this is how we operate, this is how we make this work, and then we can start to scale in the next 5 years, that's really what I'd like to do.
And then you see us like running those clinics, maybe being less in the clinical, like you yourself doing clinical.
Yeah, exactly. So I think, right now I have 2 other nurse practitioners working with me. I'm actually 3. One is very part-time, but I would like to continue to hire and do some clinical work, but also just really try to get the business going and get the clinics up and running. Again, they're small. So the model, I think I've mentioned this, the model for these clinics are really just to have an MA who does some of the office admin stuff and the nurse practitioner, just a little duo in these centers. So it's not a large staff in each place, but I always liken it to like a school clinic. It's kind of like a school clinic, but in public housing. So you kind of have like a little medical assistant person, and you have like a school nurse. So it's kind of like that model, but it's just in where you live. Yeah,
the school NP, the school nurse.
Yeah, exactly. Kind of like a school-based clinic, but instead of a school-based clinic, it's a housing-based clinic.
Help me understand this loop for me, like financially. So housing is paying for it. What's the return for them? Like, why does it matter to them if their residents end up in the ER? I could see how they Medicaid and how does housing care?
That's actually a cool question. And, it's because I think the director is just a pretty amazing person that really wants to provide amazing services. So as I mentioned before, DC Housing already has service providers. So this is true, I think, across the country. So they already employ community-based organizations to help with like after-school care and, financial literacy and educational programs. So those social service organizations already exist. We just were the missing clinical piece. There was no clinical provider. There was no medical provider. So when I approached them on this, they were like, this is amazing because we don't have this. So it's what's in it for them is really just providing kind of all of those services to their residents that live there. But the cool thing is that we're not just confined to like the residents in those buildings. Like we can see some of the other folks living in the neighborhood too. Yeah.
Wow. That is so cool. What do you wish that you knew when you first started that you know now?
Everything. No. I think I mean, there's just so much you learn as you go. I mean, what I wish I would have known more are probably local people that were doing this. I mean, I feel like even now, and I've said I've been in DC for so long, but I don't really know that many other NPs that have their own practices, that are doing similar things, that have interest in similar things. So I think for me, I think the network, knowing more about the networks, that would have been helpful. I mean, a business, I mean, you learn business. I think, some of the business skills I didn't go to business school. So I think, to me, it's kind of funny too, because I always laugh and say like, I didn't really have like a big financial roadmap. I just sort of like took it as it came and like hoped for the best. So that may not be the best to advise people. Like you might have to, work with somebody that has a finance background to kind of help you think through costs. I just tend to be more of a, let's try it and see what happens. But that would have been helpful. And and then I think the network. And I think, to me right now, what I'd love to do is like help mentor other folks. Cause I feel like as you said, it's like time. So how long have you been doing this? One of my goals is really to, serve the community, but also to help other NPs do the same thing, because I think we can do this. A lot more NPs would be willing to take risks if they knew there was like a support system somewhere out there that they could tap into.
Yeah, absolutely. So on that note, what advice would you give to the new NP, either the NP starting out or the NP who I don't mean the new NP grad, I mean new NP business entrepreneurial world. What would you say to him or her?
Yeah, I think get a mentor if you can, like try to find somebody who's done it, to help you get started. It might seem intimidating, but I think, join a network, find, a professional organization, like some of these nurse practitioner entrepreneur networks, like they're very helpful and they can connect you. Definitely, if you can find another person who's done it, I think that's going to be the mentorship is, understated.
Well, it sounds like you're in DC. You could bother Erin. Don't bother her too much.
Definitely come stop by. Yeah, absolutely.
Oh my
absolutely. God. Yeah.
Is there anything you want to tell our audience of NP entrepreneurs that maybe I didn't ask you? Part of your story that I didn't. Anything else?
Yeah, I mean, I think one thing I would say is like, you don't have to go all in either. I think there's a way to dabble in this too. I think that, this isn't part of my story because my story was very dramatic and I did just jump all in. But I think there's a way to sort of do a little side gig, start it out so that it doesn't have to be that dramatic. To me, I'm just very passionate about community health and public health. And I just think that, there are probably so many people like me that feel this way, that just feels like the service delivery isn't right for people. And I think that, we want to do big changes. We want to change the model, disrupt the model. I think, collectively, if we kind of put our heads together, we're going to have more impact. So I love this idea of this like a network of forming NPs that are all feeling the same way, right? Like maybe you're just feeling it in your gut a little bit, or maybe you're like very outspoken and advocating for it. But I think to me, that's what like I'm seeking. I think there are probably many more people like me that are also seeking that too. So I love that. I think we're definitely better together. Yeah.
I think you said two really important things. I said, so many people think they have to stop everything to start this, but then I'm like, but how do I life? So you could do gradually. I tell people keep your job and see people in the evenings, see them on the weekends. And then when that fills up, go part-time. You don't have to jump all in. I mean, if you're lucky enough, someone supports you, God bless. But if not, that's the way most of us do it. And then really finding this network. There's, you're really dedicated to the network. I'm really dedicated to the network. There's a lot of NPs that really are about lifting up the whole, everyone up together. So we do exist. We are here. And connecting is really important because we learn from each other constantly.
Yes.
Each other. This was amazing.
Thank you. This was fun. I'm so glad because I want to now that I'm sort of in it a little bit more, I think when I last talked to you, I was kind of what do I do? Some time has passed and now we've got a little bit of cadence. So I'm happy to help. I want to be more out helping as I grow this thing so I can teach others what I'm learning and, help them out.
Thanks for joining us this week. Don't forget to share this episode with other NPs because remember, we all rise together.